Hello, everyone. Welcome to BioNOW, the weekly webinar series where we discuss health, wellness, and longevity. And today we have an incredible speaker to talk about precision medicine and epigenetics. Our speaker for this webinar, Dr. Raja Singh, is trained in internal medicine with a PhD in cardiovascular physiology and has led the development of several marquee provincial initiatives, SMEs, and startups. He has chaired conference sessions at national as well as international meetings and also does television and radio talk shows for popularization of science, innovation, and creating health awareness. Before we proceed, I would request all the participants to adhere to the following rules. Please keep your microphone muted at all times as background noise can be disruptive. Use the chat box if you have any concerns or questions or face any technical issues. This webinar will be recorded and shared on various social media platforms for learning purposes. Your feedback will help us improve, so please feel free to share it with me at the end of the session. Without further ado, please join me in welcoming Dr. Raja to learn something exciting today. Over to you, Dr. Raja.
Welcome all. And the the presentation I've tried to keep it as simple as I possibly could, so that it caters to a larger audience. But there would be some technicalities, and as Amit mentioned, if you have any questions or comments or anything, feel free to use the chat box, and we can go it from there. So what we will try to do today is take a look at what precision medicine and personalized health basically are, and what is the field of epigenetics. And then, time permitting, we will go into the area of how precision medicine and personalized health are playing a role in the diagnosis and management of cardiovascular diseases. In 2013, McKinsey Global had put out this information. They had prepared a white paper in which they had tried to make a prediction of breakthrough technologies. And one of the things that they had looked at was the cost of sequencing the human genome. And the number that they came up with was $100 for the cost of whole genome sequencing, completed and report handed out within 1 hour. And so we are not there as yet, but that's a prediction that they had done in 2013, saying that this is something which would happen in the next 10 years. And so, something that we are all quite aware of is that Qatar was probably one of the first countries which launched a Qatar Genome Project, where they said that we are going to do genomic sequencing for the entire population. And this was followed by the US. And so this is something, big news, even though the Human Genome Project had pretty much most of its founders, most of its principal investigators in the US. But as you can see, US was not the leader in making any such announcements. President Barack Obama made that announcement in 2015, saying that he's going to commit a sizable amount of the budget on precision medicine initiatives. And we see that this is something which has been in the news, which has been talked about in the news from various angles for the last almost 2 decades now, maybe even more than that. What you would have heard about in the news media, in the print media, on social media, is the concept of precision health, precision medicine, and oftentimes genomics. Initially, it was genomics, and then it started moving more in the direction of precision medicine, and now we use the word precision health. So we'll try to understand that difference as well. What is the difference between precision medicine and precision health, and where does genomics fit into the larger spectrum of things? And I think at some point we can also look at the effect of any of these components on the overall economy of our modern day system, and how all of this is turning out to be a fiscally integral part of our discussions. So every time we talk about precision health, basically we are talking about different aspects of management of our patient, where we are focusing on two or three different things. One of them is the treatment of the patient, and the other is the prevention of disease. In primary focus, that's where we are trying to focus our energies. For treatment of a patient, the most critical thing for us is the ability to be able to diagnose the patient in a timely manner and determine what sort of a medical intervention would be most appropriate for the patient. So for diagnosis, the conventional wisdom tells us that we look at various parameters of the patient, and we look at the general physical examination, the data that we are collecting from blood biochemistry, imaging, tissue histopathology, maybe getting some information on the family history of the patient. And then we try to use that information to determine what is wrong with the patient. And based on our diagnosis, we try to implement some sort of an intervention for the patient. And then we also try somewhere along the route some sort of a prediction as to what might be happening, what would be the underlying cause, what is the risk of this particular thing spreading to other people in the family, in the group. And then one of the things that we try to look at is how we can prevent it in other people. So all of this put together, where we are now stepping out of our comfort zone and integrating genomics and genetics into and various other aspects of omics into the diagnosis and into the management or the treatment of the patient, and using that genomic information to do predictive and preventive management as well. That's where the concept of precision health comes in. As long as we are not taking into consideration the social environmental factors of the individual, we are basically restricting ourselves to precision medicine. The moment we start looking at lifestyle and social influences, any exposure to trauma, we try to do some sort of a host surveillance, then all of a sudden we are going into the realm of precision health. And this is a very fine difference, where often you will see people use these two terms interchangeably, but they're not interchangeable. Now, in the last couple of slides, you've heard me talk a lot about genomics and how genomics is something that we have been focusing on for the last 2 or 3 decades, and maybe even longer than that, and how it has revolutionized, or it's trying to revolutionize, the way we manage our patients, whether it's diagnosis or treatment or prevention of illness in a certain population. There is a certain basic understanding. We'll try to spend a few minutes over the next couple of slides. There is a basic understanding to what that genomics means. What does that imply for it? And so basically, if you look at this, the core of that whole thing is the DNA. And I think this is something which most people in the audience here, at least for this particular audience, are probably quite familiar with. We're looking at trillions of cells in the human body. Each one of them has 46 chromosomes and 2 million DNA, 3 billion DNA subunits, all the bases that we talk about. And these numbers, they tend to differ, depending upon which publication you're looking at. The information on the DNA is basically in the form of the bases, the subunits of the DNA, the A, T, C, G, or the U, if you're talking about certain other RNA type of things, and how they are arranged. Our ability to see how those are positioned on the DNA, what is the sequence in which they are positioned, and use that information to correlate it with the production of proteins or certain metabolites, and if there are any changes in those sequences, in the arrangement of those base pairs, that allows us to determine if something abnormal is going on in this individual, at which point that particular variation can be associated with a certain disease, and we start using the word mutation for that particular gene. So every time we say gene mutation, there is a correlation between any variation in those sequences and the development of a certain pathology. And so all of that DNA with the bases on it is tightly packed together into chromosomes, which are packed into the nucleus of the cell, and from there they control the bodily functions, the production of proteins, and all those hormones, enzymes, all those different types of things for our purposes, right? So how do we use all of that information in modern times to tell us what is going on with the patient? We talked about the different sequences, the sequence in which those base pairs are arranged on the DNA, and then we talked about how variations in those could lead to certain diseases. How are we using that information? So what we have done is that we have developed over the last 2 decades various cutting edge technologies which keep improving, and this team uses a lot of those technologies on a daily basis, where we are able to use those technologies to do whole genome sequencing or whole exome sequencing, or we are able to do SNP based assessments where we are able to build a map of the entire human genome, saying what is the sequence in which certain amino acids or bases are lined out, are put on the DNA. And then from there, we are able to see what type of variations exist in the arrangement of those sequences. And whatever differences are there in the variations in the arrangement of the sequences, they allow us to see how they may be contributing to the development of different diseases. So we are using all of that information to do genomic analysis of the individual through WGS or whole exome sequencing or whole genome sequencing. We are looking at information related to the RNA from that individual, which is in the form of transcriptomic analysis. And then, another thing that is very important to us at this point is the epigenomic analysis. And we'll try to see in another few slides what does that epigenomic analysis mean. So all this information that we get from whole genome sequencing, transcriptomics, or epigenomics, we integrate all of this to have a better understanding of the individual and what is happening in that individual. So in essence, what we try to do is all this information that we have collected, we basically layer that information and we combine that information with any of the other data that we have collected on that particular patient, the family history of the patient, the signs and symptoms that the patient might be having, what type of medications the patient is taking, to have a more precise and personalized approach to the management of the patient for diagnosis or treatment. And this information, this genomic information, transcriptomic, epigenomic, metabolomic information, we use this also to understand what would be the response of the individual to certain drugs. And further, we use this information to design our clinical studies. And so this is like a very up and coming field where what we are working on right now is to use in silico approaches. So if I have all this information around the patient, which tells me that he has these genes, these out of those have any variations in them, this is the medications he's taking, this is his family history and everything, can I build algorithms, predictive algorithms, which will tell me that if, for example, I change his current medication from A to B, then what is his likely response going to be to that change in the medication? So that information, the way that predictive algorithm would work is it would allow us to make a prediction on how that individual would respond to that particular change. And that predictive algorithm can be used for in silico development of a clinical trial. So we can simulate the entire clinical trial even before we have started recruiting the patients, and we can see what would be the outcome of that. And then a lot of this information is used these days for economic modeling for healthcare purposes. So, in essence, the value proposition that we have of genomics and personalized medicine is that initially we used to have what is there on the left hand side of the screen. We used to have a one size fits all type of an approach to management of our patients. If 500 milligrams of Tylenol have worked for me, then the physician would make an assumption that that 500 milligram would also work for patient X or patient Y, irrespective of whether that patient X is a male patient or a female patient or an elderly patient or a child. We have done, alterations in the doses based on what we believe is likely to cause toxicity in a certain individual, but that's where it ends. But the way genomics and personalized medicine is trying to help us is that we are trying to shift our approach from a one size fit all to a more precise and personalized approach to the management of the patient, where we are looking at the patient as a unique independent entity which may or may not have similarities with other patients before him. And this allows us to identify those type of medications or those type of management approaches which would improve the quality of his life, which would reduce the burden of care or of disease, and also reduce the chances of adverse effects in that individual. And so we try to follow with precision medicine what we call as the 3R principle. In the 3R principle, we try to see from, for example, if pharmacogenomic management point of view, that what is the likely response of an individual to a drug? That's one. What is the risk that he carries if he was to given a certain dosage of that drug? And then which drugs or combinations of drugs are likely to work in the individual, but on the other hand, which combinations or individual drugs may not work. So in other effects, he or she may actually show some resistance to that drug, and which is something we have often seen with chemotherapy or the use of antibiotics. So, and then, one of the other things that is very critical for us at this point from a precision medicine point of view is that how we can use this information for any underrepresented communities. And so, underrepresented communities, by definition, WHO definition, Health Canada definition, would be women, ethnic populations, or indigenous populations. And so, any population which is considered not representative enough in various clinical trials or clinical studies are considered as underrepresented. And so think about it, that all of these categories are currently being prescribed treatments, various type of drugs based on information which has been collected from clinical trials in the last countless decades, at least 3 4 5 decades for sure, where majority of the population or majority of the patients that were recruited to those clinical trials were white Caucasian males. Ethnic populations, specifically blacks and maybe women, have been recruited to clinical studies and clinical trials for investigation of drugs only in the last maybe 10 to 20 years. So most of the medication that we are doling out to people right now is based on studies and investigations that we have done in white Caucasian male populations. And so precision medicine, where we are using genomic or epigenomic information of the patient, becomes very critical when we are looking at these underrepresented communities. And so, okay, so how are we doing? I hope everybody is still awake. Okay, all right, that's good. So, in precision medicine, what we are looking at doing is that every time we will have a study, or we would be looking at collection of a certain amount of data. What we are looking at is recruitment of an ethnically diverse cohort of people. We will collect data, analyze that data, and then we will use predictive algorithms or various programs to analyze and sift through the data so that the information that we are collecting becomes more representative and is not limited to one specific group only. And this would allow us to improve the efficiency and outcome of our clinical research, any of our drug discovery or device discovery programs. Whatever findings that we already have, we would be able to validate them in a more precise and personalized manner. And then we will be able to socialize all of this information. So all the data that we have collected, once we curate all of this data, this data will allow us to do healthcare modeling. So in healthcare modeling, what we are trying to do is that we are trying to see, let's take the example of Alberta, for example. So the government of Alberta says that we have a budget of $4 billion that we are going to dedicate every year to our healthcare system. Now, there are likely to be disparities in access to care based on where people are located. So, for example, people who are living on reserves or off the grid or in the up north areas, or people who are gender diverse, LGBTQ, or ethnic minorities, their access to care would be different. But the information that we have collected, the genomic information that we will collect for these patients, the epigenomic information that we will collect for these patients, correlated with any of their family history, any of their lifestyle changes, it would allow us to see how those populations are more likely to behave, what is their risk to a certain disease, how fast that disease is likely to progress in those patients. And so, in the case of healthcare modeling, what we can do is that we can use all of this information to inform policy where we are able to improve the efficiency of the healthcare delivery system for those at risk populations. And by doing so, we are able to reduce the burden of healthcare cost, which might happen because all of those people are more likely to get sick. For example, there was a study that we published a couple of months back where we looked at the disparity in access to care in indigenous men and how it was affecting their risk for prostate cancer. So, what we found was that men who were living on reserves, compared to even the Métis population living in the cities and the general population living in Edmonton or Calgary or Red Deer, their diagnosis of prostate cancer was happening much later compared to people who were living in the metropolitan cities. And so, if that patient is getting diagnosed later, chances of that patient having advanced prostate cancer is much higher. And therefore, that patient becomes a higher burden on the healthcare system. And so, the genomic, epigenomic, metagenomic, metabolomic, transcriptomic data that we are collecting on our patients, combined with their family history, their social lifestyles, and all those other parameters, allows us to develop healthcare models that will tell us that which populations are at our higher risk for a certain disease and how and what steps can we take. For example, in the case of prostate cancer, all you need to do is a simple PSA test, which could be done maybe every 3 months or every 4 months for these at risk populations, right? So, by simply doing a blood test, PSA test for these populations, we will be able to catch them much earlier, reducing the cost to the healthcare and the exchequer. So that's the value proposition that we bring to the table for these type of ethnically diverse groups by using genomic and precision medicine information. Okay, so that was a very fast and high level introduction to precision medicine and personalized health. Now, if there are any questions, I'm more than happy to take them now, or you are welcome to put them in the chat box, and then we can try to attend those at the end. I mean, I know I'm trying to go at a very high speed because there are two topics I'm trying to cover today. And but then, feel free, as I said, to type in your questions into the chat box, and we'll take it now or or at the end of the program, the lecture. The second part is around epigenetics. So, under the precision medicine umbrella, precision health umbrella, what we talked about earlier was multiple components. And if you remember that slide where I talked about how we layer all of that information, we talked about genomics, epigenomics, transcriptomics, you know, metabolomics, and all transcriptomics, and all other types of omics information. One of the critical pieces in that entire discussion is epigenomics. And I'll tell you why. We are all born with a certain set of genes that we cannot change. Actually, now we can through the advent of CRISPR and certain other technologies. But let's say if we discount that, then the set of genes I'm born with, I can't change them. So does that mean that I'm going to die with, or I'm already, castigated, that I have a certain mutation in BRCA1? So chances are that, at some point, sooner or later, I am going to develop breast cancer or prostate cancer. The answer is no. And that's where epigenomics comes in. Just like how we talked about the genomic information, where we talked about the various base pairs, where various bases or the sequences in which those bases are aligned, there is also an epigenetic code that we carry. And so it's basically a sequence of DNA methylation and histone modifications in eukaryotic cells, right? Which we call as epigenetic marks, which is something that we can identify and which helps us to see what are the diseases that can manifest in this person. And from there, we can control that. And those epigenetic marks are modifiable, right? And so the genomics of the individual is what that individual is born with, and which will determine what hormones, what enzymes, and certain other things that individual will have. But how will they be different from other individuals is something that is driven by epigenetics, and which can be quantified by those epigenetic marks or epigenetic markers that we just talked about. So, to start with, the easiest way to understand epigenetics is something which is happening above. Epi means above. So, we have our set of genes, and above those genes are or is the field of epigenetics. And so, these are heritable changes that a person can inherit from their parents and can transmit to their offspring, factors which actually influence the expression of genes in that individual. So, if you think about that individual having a set of genes here, and here are the epigenetic factors, then these epigenetic factors are those modifiable, inheritable factors that the individual has inherited from their parents and can transmit to their offspring, which are affecting the genes underneath. And so, how they affect them is by simply turning genes on or off. As simple as turning a light switch on or off in your room, which would, you turn it on, the light comes on, you turn it off, the light goes out. And so think about that in terms of gene expression. You turn a gene on, It would start expressing a protein or an enzyme. If you turn it off, it might stop. Think about insulin, for example. There are various epigenetic factors which could influence the production of insulin. And so if there is a factor which turns the genes responsible for insulin production off, then that individual is likely to have a low level of insulin, leading to diabetes, insulin dependent diabetes in that individual. And so, what are those epigenetic factors? We've talked about epigenetic factors a lot, which are influencing gene expression. But what are those things? So, those epigenetic factors are basically internal or external environmental factors which are involved in regulation of gene expression. So these internal or external environmental factors could be, a person is smoking. Smoking would be an external environmental factor. The individual is exposed to radiation. That's an epigenetic environmental factor. The food that people eat, even changes in their microbiome composition, are considered as epigenetic factors that can influence gene expression in those individuals. So all of these things are considered as, if you think about the genetics as the alphabets of a certain language, the language of our body, then epigenetics would be the punctuation, the grammar, where a small change in an apostrophe or a comma or a semicolon here and there would change the meaning of the entire sentence. So those external or internal environmental factors, they would change how genes are expressing themselves, how they're going about doing their business, making an individual look like how they should be looking. The color of their hair, the color of their eyes, their height, their weight, all of those things. And so these are the factors, the epigenetic factors are the ones which are responsible for the various levels of differentiation that we see in cells, that differentiate cells into a full-fledged tissue or an organ. And the best way to understand that is through this flow chart, where we all know that we have stem cells, which are the pluripotent embryonic stem cells, and how we have the development of the ectoderm, the endoderm, and the mesoderm, and how each one of those is leading to the development of our skin, the neural tubes, the various organs, whether it's the GIT or the lungs, and the bones, the muscles, and all those things. Now, the differentiation of those stem cells into each one of these cells, just for uh, just for a very simplicity purpose, the change of all of those stem cells into various specialized organs and tissues is something which is happening under the effect of the epigenetic factors that that particular individual has inherited from their parents. Now, we talked about in the beginning epigenetic factors, and we talked about epigenetic marks and what those marks are. At a very high level, the easiest way to understand what those epigenetic marks are: methylation, histone modifications, and RNA mediated modifications. Methylation is where the CH3 group, methyl group, is basically added or removed from certain sites on the DNA. The attachment or the removal of the methyl group would basically make the sequence at that particular site turn on or turn off. Same thing with the histone modifications, which is mostly around how the histone bodies are revolved around the nuclear material. And so all of these factors, for just to keep it simple without going into too much detail, these epigenetic modifications through methylation, histone modifications, even acetylation, demethylation, they acting through various sites, for example the CpG sites, they would introduce those epigenetic changes which would influence the expression of genes that that individual has inherited from their parents. And it comes down to the age old thing that we have been discussing of nature versus nurture, where we say that we are defined by, oftentimes we say we are defined by what we eat, the type of gut microbiome or skin microbiome we have, the environmental exposures that we are exposed to. It's not just limited to that, but it also goes a bit further back to saying that we are defined by what our forefathers ate, the circadian rhythms they had, the type of microbiome that they had, our forefathers or our mothers. And most of these influences, and this is something very important for us to understand, that most of these influences are not captured in our DNA, but they are still inherited, and they are transferred transgenerationally from one generation to another. And so, this is just to give you a high level idea of what are those environmental factors which can basically influence the epigenetic modification of our genes. Now, this is a question I have. How many of you know who this person is in the picture? Not the one licking the plate, but the one next to him. So if you know who this person is, maybe you can put it in the chat box and we will go from there. And also let me know how many of you have actually heard of Hunger Winter. This is a classic example of what epigenetics is. And Hunger Winter happened basically during the Second World War, where the German troops cut off large swaths of Dutch villages, and they starved the people living there. So they would cut off the supply of food to those areas, and people were starved there. They would invariably end up eating simply potatoes or starches and those type of things. They were deprived of mostly proteins. And so these people who were living at that point, the nutritional deprivation that they had, that nutritional deprivation led to epigenetic modifications in various nutritional pathways, metabolism pathways in those individuals that were transgenerationally inherited. And even today, individuals of Dutch ancestry who were exposed to the hunger winter show signs of those deprivation. And so this is a classical example of epigenetic influences, epigenetic changes, which occur transgenerationally, where you won't see any genetic mutations, any modifications in the gene sequences of those individuals, but they still show those things. And I'm not sure if anybody has written who this lovely lady is. Okay, well, so let's leave it there. She was a Hollywood actress, considered to be one of the most beautiful ones. And the reason for her beauty, the reason for her petite well being, her physical well being, the way she looked, the way she never put on weight and everything, is actually attributed to her exposure to the hunger winter and the epigenetic influences of that, which happened during the Second World War. And so we'll come back to her name later on. Another example of epigenetics, a real world example, is how you have a colony of bees, and one of those bees ends up being the queen. Everybody else ends up being subservient to her. And that happens under the effect of a royal jelly, which which is basically given to a specific to a specific bee, and that royal jelly turns that bee into a queen bee, and everybody else ends up being a worker bee for that. And so that change in the bee, making it a making it a queen bee, is an epigenetic change that happens under the nutritional effect of the consumption of that royal jelly. Anirudh, how are we doing for time?
We're still good.
We're still good? Okay.
Yeah, not a
I
problem.
think I have another couple of more slides. So
Hmm.
I'll try to quickly go through them so that we have more time for questions at the end.
All right.
And so a lot of these studies, a lot of the data that we have on gene expression and on epigenetics has come from twin studies, where we try to see that if these twins they share the same set of genes, then they should have the same set of diseases, the same set of physical behavior, physical outlook, hair color, all those other things. But oftentimes what we find is that even people who are twins do not end up having same exhibits of the phenotype, the physical characteristics. You will see differences in, even, like, it's rare, but even in hair color, eye color, but that's more on the rarer side. Most of the differences will happen on their acquiring any diseases, and that happens because the environmental exposure that they have to various environmental pollutants, the type of food that they eat, the societal things that they get exposed to, they produce epigenetic changes in them which are not the same. So even though these individuals they have the same set of genes, the expression of those genes is altered over a period of time because of their exposure to different environmental stimuli. And something to keep in mind here from the perspective of epigenetics is that this plays a very, very big role uh, in ethnic populations, because think of think of an ethnic group as a large family which is very, very diverse. Their exposure to various environmental influences, whether it's the food that they eat, the social influences that they have, the lifestyle, they're all different. And so the exposure to those different lifestyle stimulants causes their genes to express themselves differently. And that's one of the fundamental reasons why various groups are considered as ethnically diverse, because they would have end up having different skin color, having different hair color, eye color, maybe which is happening under the effect of exposure to sunlight for certain people. And so the field of epigenetics therefore becomes very, very critical, because it allows us to use that epigenetic information from those ethnically diverse groups to help better understand the progression of a certain disease in those groups, so that we are not treating them the same way as we are treating the larger minority group. And so that goes back to the point that we were discussing earlier, where precision medicine and personalized health and epigenetics plays a very important role in not only the diagnosis of the individual, but in the treatment of the individual, and also in the prediction of the progression of a disease in that individual. And so, this is something we are all familiar with if you're a Simpsons fan. So traditionally, and this is a, I won't spend too much time here. Traditionally, what we believe in is that epigenetics is soft inheritance. And so these are not permanent features. But researchers now believe that exposure to even those environmental stimulants, which we consider as which produce epigenetic changes and which we consider as transgenerationally inheritable, even if they're considered as soft inheritance, if those environmental stimuli exist for a longer period of time, if they're persistently there, then it would become hard inheritance. So, hard inheritance is that you would see phenotypic changes in that particular cohort, in that particular ethnic group, or that particular subset of the population over a period of time, again and again and again, and they would not go away. And And so one of the things that you have heard me talk about is transgenerational inheritance of these epigenetic factors. And the best way to understand that is that if a mother smokes while she's pregnant and the fetus happens to be a female child, then the effects of smoking on that female child would carry on for at least 3 generations, whatever those side effects are. They will carry on in each one of those subsequent generations, not just limited to the very first generation of the mother. And it's not just limited to smoking, which is easily quantifiable, but it's also seen more often in cases of stress, where stress is causing methylation of the individual, not just the individual, but also of the child that that individual might be carrying or giving birth to subsequently. And it's not just limited to smoking and stress, but it could also be coming from a various other environmental toxins, alcohol intake histories, and things like that. People getting pregnant at a higher age, at an older age, the gender of the individual involved, and or the ethnicity. And so, for example, there are many studies which have looked at societal trauma or exposure to war. For example, you know how we see this happen very unfortunately in the Middle East, especially in Palestine, and some of those individuals actually have been studied for any epigenetic changes, and those have been found to be transgenerationally inherited over a period of time. And so all of these things, they lead to methylation, how we were talking about in one of the earlier slides, you know how various epigenetic influences are changing gene expression, and we talked about methylation, histone modifications, and things like that. So all of these factors, they are responsible for methylation of various regions of the DNA. And based on where they're causing that methylation or hypomethylation, we see those physical manifestations, the phenotypic manifestations of that. And so we have heard this again, and we talked about it earlier also, that we are what we eat, because the food that we are eating, that food is contributing significantly to these epigenetic changes that we are talking about through the process of methylation, largely methylation. And I'll give you a small example of that to illustrate the point. We all talk about pregnant women, and we always tell pregnant women to take folic acid, and we'll give them folic acid supplements and things like that. Why would we do that? And we have been doing it mostly because we saw neural tube defects in those individuals, but we never knew what was causing those neural tube defects. And so folic acid is involved in one of the key pathways, the methionine pathway, which is critically, integrally responsible for DNA methylation. And so in the absence of that, various changes in the mother happen that can lead to neural tube defects in the offspring. So that's a very good example if you're trying to understand the effect of diet on an individual, and how that effect on the individual could epigenetically influence the offspring in that individual. So this flow chart would try to capture all of that information for you. So in the last few slides, we have talked about epigenetics. We have talked about various factors which could be responsible for causing those epigenetic changes. And we have talked about how those epigenetic changes happen. We talked about methylation, histone modifications, demethylation, and things like that. And then we talked about the environmental stimuli and how they are transgenerationally, those epigenetic factors are transgenerationally inherited. And so if you think about an individual who is at that stage where they are ready to conceive, what are the epigenetic markers that they have developed? We talked about I showed you that cartoon about three women where the mother was smoking. So think about that and the epigenetic changes which it is producing in that mother. And so the moment that individual conceives, she passes those on to the daughter. And those epigenetic markers, those factors which are being transferred to the individual, to the fetus, are now influencing the flexible epigenome of that fetus and influencing the development of that particular fetus. And so, what is happening in that individual at that stage? Cell differentiation is happening, development of various organs is happening. And so, all the instruction which that individual has got from the parents of how that cell differentiation and organ development should happen, because of those epigenetic markers, is getting skewed now. It's getting altered now. And so, as that individual progresses, that fetus becomes a child, it becomes an adult, it's still carrying those epigenetic markers from the parent. But now, because of the various environmental stimuli that that individual is getting exposed to, it's developing which it will transfer to its own offsprings. So there is a cyclical process which is transgenerationally going on. From a clinical perspective, all of these epigenetic markers, they carry a huge diagnostic and prognostic value for us because we can detect them, they're tangible, we can detect them, we can measure them, and if and where we find them, we can use them to make a prediction of what is the risk of that individual getting a certain disease. And since these are modifiable, we can also use those for therapeutic purposes for the treatment of that individual. And so that's where I'm probably going to hold it off, Anirudh, because the third thing that I wanted to discuss was
Hmm.
precision medicine and epigenetics and how we are using that in the management of cardiovascular diseases. But I think looking at the time, I'm going to hold that off for maybe a subsequent discussion. And what we will do is we will
Hmm.
try to take any questions that there might be on what we have discussed so far. Is that okay with you?
All right, that could work because then we can have a follow up on the current webinar with we can continue from the role of genomics in cardiovascular disease, right?
Sounds good. You're the boss. I will let you decide whichever way you feel is good.
And thank you so much, Dr. Raja. We're really grateful for you sharing your wealth of knowledge with all of us.
I tried to
And
rush through everything, so I hope I wasn't too fast and it was comprehensible. And at the end of the day, it made some sense.
oh, you it wasn't fast at all. You went like it was very comprehensive for all of us.
Okay,
And just for the actress during the famine um, thing, right? Is she Audrey Hepburn?
absolutely.
Yay!
She's
Okay.
Audrey Hepburn.
All right. So now Dr.
Excellent
Raja
job.
will take questions from the audience on the discussion we've had today. Please use the chat box for asking questions or request to unmute in case you'd like to use your microphone. We'll give you a minute.
I think there was a question I briefly saw come up from Brendan.
I'll just go through the questions.
Brendan, feel free to unmute yourself if you want to ask it. Oh, there it is.
So Brendan is asking, is there a chance to modify epigenetics in a yet to be born child to avoid potential genetic diseases?
So, Brendan, that's a great question, and I wish there was a more straightforward answer to that question. The the easier short answer to that is yes, it's doable. But the caveat to that is if you Google there are certain new technologies which are coming up, and I had some of those slides, but I sort of avoided those. Didn't want to make it too complex. If you Google something by the name of CRISPR, CRISPR, it's a new enzymatic based technique which has been developed. I mean, it's not so new now, it's almost like 5-10 years old now, with which we can actually modify the not just the epigenetic factors, the epigenetic markers in the unborn child, in the fetus, but we can also there was actually a case in England where they tried to even do gene therapy. So they tried to do CRISPR based gene editing of a fetus before the fetus was even born. So the answer to your question is that yes, those that possibility is definitely there. However, we are not at that stage where those technologies are available for general use of the public. In very rare instances, yes, they can be used, but right now they're mostly being used for research purposes only. And actually, I think everybody in this group should try to look at CRISPR, because CRISPR is a very interesting technology from 2 points of view. One is the technology itself, and the second thing is the history behind the technology, how it was developed, and how there was a big, massively big fight between Jennifer Doudna and Feng Zhang, the people who developed the technology, how they fell apart, how they took each other to court, and their respective universities ended up spending millions of dollars to protect that. So it's a good thing, which you guys should look into. Uh, what was there was another question I think I saw. Can we change our metabolic activity caused by methylation patterns through diet and exercise? Absolutely, we can. Yes, and that's another part which hopefully we'll get a chance to discuss at some point. Is the role of nutrition? We briefly touched it. The role of nutrition in modifying or introducing epigenetic markers, and how that influences your gut microbiome, and through modification of your dietary lifestyle you can influence your gut microbiome, and how through influencing and bringing changes in your gut microbiome you can actually influence your metabolic rate. So yes, absolutely, that's doable. Okay, Alina says, I believe using CRISPR was banned. Alina, to the best of my knowledge, CRISPR has never been approved by FDA or Health Canada for clinical uses. It has only been used for research purposes. But I'm not aware of this Chinese incident that you're talking about. So, Raju has a question. With epigenetic markers, will reduce the chances of hereditary diseases by modifying of lifestyle. Um, Raju, the most common examples that I can give you, and that was, the part that we were going to discuss about cardiovascular diseases. Basically, you can modify all chronic diseases. So, starting with cardiovascular diseases, metabolic disorders like diabetes, and even uh, diseases like cancer. So people have been shown, well, we know that there are cases where I mean, Meenal can tell you about this, all the patients that she has done tests on. We have had many patients who have a very strong family history of breast cancer, and these patients, they carry mutations in BRCA1, BRCA2, but they have never exhibited any symptoms of breast cancer or prostate cancer in males, right? Simply because the environmental influences, dietary factors, various other exposures that their mothers or their fathers had, they don't have them. And so, because of those changes in their lifestyle, the epigenetic influences have been taken away, which, even though they carry mutations in BRCA1, BRCA2, or certain other genes, are not allowing for the phenotype to express itself. So they are not leading to the manifestation of the disease itself, to the cancer itself, right? So that's something very important. Same thing can be said for diabetes. The environmental lifestyle changes that we make, even if there is a strong family history of diabetes or cardiac disease, that will prevent those from happening. So those are some high level examples that I can definitely give you. But then additionally, we can also talk about inflammatory bowel disease, Crohn's disease, those type of things. I hope that answers your question, Raju. Okay, any other questions?
If anyone has a question, you can mention it on the chat box or ask to unmute yourself if you'd like to use the microphone.
I think this is a very intelligent audience. Is there any specific type of medicine that we cannot personalize it on specific population? So, Neda, if I understand your question, what you're saying is that if there are any medications which, because of their pharmacogenomic or epigenomic influences, cannot be prescribed to a certain population. So, if I understand that question, then the answer is yes. Yeah, yeah, yeah. So, that's where the pharmacogenomic part comes in. Pharmacogenomically, I can definitely give you an example, and this example is there in my next few slides on cardiovascular. The best example is warfarin, and so warfarin has been used as a blood thinner, as a clot buster, to inhibit platelet aggregation for a very long period of time. However, it's not very popular in patients from Southeast Asia or Asia in general. And so physicians don't prescribe warfarin to those patients because what they found was that these patients, they basically had no response to warfarin. And so they shifted those patients to different doses of aspirin, or there's a newer medication that they use, topic dogrel and things like that. So what pharmacogenomics has shown us is that people from Southeast Asia are actually responsive to warfarin. It's just that they need a slightly higher dose of warfarin. So all you needed to do was modify the dose of warfarin. You don't need to stop it because it's probably one of the most helpful medications that you can use in those cardiac patients with atherosclerosis. So that's the information, that the value proposition of pharmacogenomics, that allows us to better understand the response of not just the individual, but the individual subset of the population also to a particular drug. And then, there are certain other drugs that we can talk about for sure. Yeah. Okay. Anything else?
We'll just wait for one more question if anyone has it from the audience. Just wait a minute.
Okay.
All right, it seems like everyone has asked their questions that they wanted to. And
Perfect.
that brings us to the end of this webinar. I hope you've all enjoyed learning more on precision medicine and epigenetics. Thank you all for your questions. Also, I'd like to take the time out and thank all of you, our virtual audience, who joined us from within Canada and around the world. It's incredible to see such a diverse group of individuals coming together to explore the science behind precision medicine. All right, before we officially wrap up, I'd like to take a moment to express our gratitude towards Dr. Raja for taking the time out and generously sharing your experience and knowledge with us today. It has been
Uh,
a really informative session, and we cannot wait for the continuation to this webinar in the series.
Sounds good. Thank you, Anirudh, and thank you to all of you for your patience. I hope I didn't put you to sleep, and we will definitely look forward to the next lecture where we can talk about cardiovascular diseases. We can talk about microbiome and many other things. So look forward to that. And you
Yes.
guys have a wonderful evening. Thank you so
Yep.
much, all of you.
Yep. And I encourage all of you to stay curious, keep learning, and join us next week for the webinar on what is IBS or irritable bowel syndrome by Dr. Christian Turbide. Please remember, the more we know, the better equipped we are to make informed decisions and improve our lives and of the people around us. Thank you once again for being a part of this webinar. Goodbye and see you next week.